Dear class, this is the second part on autocoid and autocoid antagonists. It has been estimated that tens of millions of men and women in the United States suffer from severe migraine headaches. Migraine can usually be distinguished clinically from the two other common types of headaches, that is, cluster headache and tension type headache, by its characteristic as shown in the figure there. Migraines, for example, present as a pulsatile throbbing pain, whereas cluster headaches present as excruciating sharp steady pain, and tension type headache as dull pain with a persistent tightening feeling in the head. Patients with severe migraine headaches report 1 to 5 attacks per month of moderate to severe pain, usually unilateral. The headaches affect patients for a major part of their lives and result in considerable health costs. There are two main types of migraine headaches. The first, migraine with aura, previously called common migraine, is a severe unilateral pulsating headache that typically lasts from 2 to 72 hours. These headaches are often aggravated by physical activity and are accompanied by nausea, vomiting, photophobia, and phonophobia. Approximately 85% of patients with migraine do not have aura. In the second type, migraine with aura, previously called classic migraine, the headache is preceded by neurologic symptoms called auras, which can be visual, sensory, and/or cause speech or motor disturbances. Most commonly, these prodromal symptoms are visual, occurring approximately pain begins. In 15% of migraine patients whose headache is preceded by an aura, the aura itself allows diagnosis. The headache itself in migraines with or without aura is similar. For both types of migraine, women are threefold more likely than men to experience either type of migraine. This diagram just illustrates the natural history of migraine. The first manifestation of migraine with aura is a spreading depression of neuronal activity accompanied by reduced blood flow in the most posterior part of the cerebral hemisphere. This hypoperfusion gradually spread forward over the surface of the cortex to other contiguous areas of the brain. The vascular alteration is accompanied by functional changes. For example, the hypoperfused region show an abnormal response to changes in arterial partial pressure of carbon dioxide. The hypoperfusion persists throughout the aura and well into the headache phase, after which hyperperfusion occur. Patients who have migraine without aura do not show hypoperfusion. However, the pain of both types of migraine may be due to extracranial and intracranial arterial dilation. This stretching leads to a release of neuroactive molecules such as substance P. Acute treatment can be classified as non-specific, symptomatic, or migraine-specific. Non-specific treatment include analgesics such as NSAIDs and antiemetics such as prochlorperazine to control vomiting. Opioids are reserved as a rescue medication when other treatments of a severe migraine attack are not successful. Specific migraine therapy include triptans and dihydroergotamine, both of which are 5-HT1D receptor agonists. It has been proposed that activation of 5-HT1D receptor by this agent leads either to vasoconstriction or to inhibition of the release of pro-inflammatory neuropeptides on the trigeminal nerve innervating cranial blood vessels. Triptan. This class of drug includes sumatriptan, rizatriptan, zolmitriptan. This agent rapidly and effectively abort or markedly reduce the severity of migraine headaches in about 70% of patients. The triptans are serotonin agonists acting at a subgroup of serotonin receptor found on small peripheral nerves that innervate the intracranial vasculature. The nausea that occur with dihydroergotamine and the vasoconstriction caused by ergotamine are much less pronounced with triptans, particularly rizatriptan and zolmitriptan. Sumatriptan is given subcutaneously, intranasally, and orally. Zolmitriptan is available orally and by nasal spray. The onset of the parenteral drug is about 20 minutes compared with 1 to 2 hours when the drug is administered orally. Some of the adverse side effects: significant elevation of blood pressure and cardiac events have been reported with triptan use. Therefore, triptan should not be administered to patients with risk factor for coronary artery disease without performing a cardiac evaluation prior to administration. Other adverse effects with the use of triptan include pain and pressure sensation in the chest, neck, throat, and jaw. Dihydroergotamine, a derivative of ergotamine, is administered intravenously and has an efficacy similar to that of sumatriptan, but nausea is a common adverse effect. Therapy to prevent migraine is indicated if the attack occurs 2 or more times a month and if headaches are severe or complicated by serious neurologic signs. Propranolol is a drug of choice, but other beta blockers, particularly nadolol, have been shown to be effective. Other drugs that are effective for prevention of recurrent refractory severe migraine include the tricyclic antidepressant like amitriptyline, anticonvulsant drug like divalproex, and calcium channel blocker like verapamil.